Hi, I'm Linda Vignapiano. A lot of you know me already. I'm Dr. Sher's personal clinical coordinator, and I'm the executive clinical coordinator for Sher Institutes, all of our locations. Today, I'm going to be speaking to you specifically about, for those of you who are heading into the St. Louis office to do a cycle in St. Louis, I'm going to kind of gear this all towards that and the staff there, etc. Of course, I want to introduce you first to Mary Kay Montgomery. She's the RN. She's the clinical manager over in our St. Louis office. And here on the St. Louis webpage, you'll be able to find a picture of her and her contact and her email, etc. She's gonna be able to do everything I'm doing for you. But we wanted to do something where I can ahead of time get a lot of information out to you guys, kind of a what to expect, a what's next, from the very beginning to the very end. Because whether you just had a consult with the doctor and you want to know what's next, you know, what to expect, what do I do now, I got a lot of info, or you're all the way down to it's the day of your embryo transfer and you want to know what can I expect, what's next. I'm going to go through all that with you guys. I've learned everything. The information I have is mostly because for 15 years my patients have asked me these questions, and my patients have told me this is the information they've needed. So I've become very good at that, because you guys have geared me towards what I have to do and what I have to know, and what more important, what you guys have to know. So Mary Kay Montgomery, she's the clinical manager in St. Louis. I'm always reachable. I'm mostly in Las Vegas with Dr. Sher, but I travel out to St. Louis and I do cycles with him there. I help out there. I coordinate there. Almost wherever he is, you tend to find me somewhere around there. Most important, I'm always accessible by email. You'll probably find my information on this page as well, but certainly I'm going to give it to you now because I want all of you to always feel free, no matter what you're doing, where you're cycling, where you're at, to say, I'm going to shoot Linda an email. Seems like I know Linda. We talk all the time. So I have a question for her, and I'm going to be able to help you out with that. My email address is V as in Victor, lindav@sherinstitute.com. So you use that whenever you want to. So, all right, what am I doing today? Basically, I want to start, like I said, at the beginning and talk about what to expect, mostly in going through a cycle, getting into a cycle. Elsewhere on this website, there are plenty of videos about how to do injections that I've done. So certainly when it gets down into the details of what exactly are the medications I'm using and how to do them, when to do them, what needles to use, you're going to be able to find all of that information on this website as well under injection instructions. So you're not going to find that in this video today, but mostly this is just a lot of information that all of you at one point or another need to hear, and probably need to hear a couple of times too. All right, so let's start at the beginning. Let's start at the beginning where you've had a consult with Dr. Dial, Dr. Sher, Dr. Witten. You've gotten a lot of information. You've gotten a lot of questions answered. You're probably a little overwhelmed with the amount of information you've gotten. Good, bad. Usually it's good, because after talking to these docs, you find that, you know what? There's a path out there for me. There's a road out there for me. And it sounds like this person, this doctor I've just spoke to, he's going to be a great map reader, and he's going to get me to where I need to go. And it's going to be a very positive and optimistic feeling. But yet, again, that's great. What do I do now? What do I do next? More than likely, you're in the system, so to speak, so that you've already, if you haven't already, you're hooked up to speak to one of the office manager who's going to got to go through all that financial side of everything, got to check out insurance, got to get the pre-authorization, got to do a lot of things like that. And you're going to have probably appointments specifically to go through all that, learn about our different financial plans, what's best for you, etc. So that's going to be happening probably soon after you've had your consult with the doctor. Now, the way we do our cycles out in St. Louis is we have our cycles with pre-selected dates. So we know pretty much, at least going forward for the next 6 months, I know exactly when I'm going to be having these cycles. These IVF cycles are timed specifically, so this way we make sure we know everybody's available, the doctor's in town. More important, you actually can plan your life around this cycle. I mean, a full IVF cycle is going to take you a couple of weeks to accomplish. You want to make sure if you've got to travel, you want to make sure you've got your travel arranged. You got to make sure you got your time off work, all that kind of stuff. So a lot of the pre-planning of the cycles works for you as well. Now, once you've talked to the doctor and once you've spoken with the financial individual and you've gotten to the point that you want to start moving forward a little bit, maybe the doctor's talked a lot about some testing that you need to have done. Again, generally, the doctor will make sure he's hooked you up with the right individual in the clinical side of things. Could be one of our medical assistants, Jamie or Penny, or even maybe Mary Kay herself, to get going on some of that testing. They will take care of ordering immune testing or getting you the orders necessary so you guys can get started on your testing. But there's going to be a point where, like I said, you're going to be ready to move forward to select your cycle. Now, one of the things you're going to want to keep in mind is that in order to have these pre-selected cycle dates, we do need to get you on a birth control pill. So when we talk about answering the question, so when do I want to do this? When do I want to cycle? Maybe the summer's a good time for me. Maybe doing this yesterday is a good time for me. Whatever your clock is, keep in mind it takes, I'm going to say, about 4 to 6 weeks, even maybe comfortably up to 8 weeks to get ready for an IVF cycle. Most important is what we got to catch ahead of time, and at least a month ahead of time, because we've got to catch a period because we've got to get going on the birth control pill. This is what kind of keeps us in a nice little holding pattern, and this is what makes those specific cycle dates. Well, we got an April 1st cycle coming up. We've got an April 29th, May, whatever the dates are. They're coming up and you want to pick one of those dates. We make that date work with your body because we use a birth control pill. So that's one thing you're going to want to keep in mind. In other words, you wouldn't want to call 2 weeks like, well, I'll use an example. Let's say we're interested in the April 29th cycle. Well, I wouldn't want you to think, geez, I guess I better call by the 20th of April so I can get going in that cycle. No. You want to keep in mind, again, 4 to 6 weeks, even sometimes 8 weeks, you want to, contact that office manager to say, sign me up, commit me to that cycle. I want to get moving. I want to start meeting with the coordinator and start planning this cycle. So that's one thing, time frame wise, I want you to keep in mind. Once you do decide, like I said, you've picked a cycle date, you've got that period in time there. Maybe you've already started on some of the testing that the docs want you to have done. Then, like I said, you let the office manager know, sign me up. She's actually going to, actually fill you in, put you in on that cycle date. Most important is you've got to have your first coordination appointment. Now that'll be with one of the clinical coordinators there in St. Louis. This is called a chart review appointment, and it's just a big hodgepodge of learning a whole lot of things about this cycle. Now some of you will come in and already have had previous IVFs, maybe even IVFs within this clinic, elsewhere, what have you. Every IVF cycle is different. And sometimes the more experience you have at doing IVF, the more questions you have. So I never assume just because somebody's had an IVF before that, they're an old hand and they're not going to need much. Sometimes those are my patients who need even more because they've gotten a lot smarter about all this and they have a lot more questions and they want a lot more information. But this first appointment, this chart review appointment, is primarily what I'm going to go over next with you in the next video. Now, kind of keeping it rough for a minute, there's going to be 2 groups of people that I'm going to have, and I'm going to kind of split this into 2 videos geared towards each group because they're different groups. The first group is what I'm going to call the stimulation group. This is my group of IVF patients who are going to be on fertility drugs, stimulation drugs, because they are, going to be egg donors, because they are going to stimulate to do a staggered IVF, because they're going to do a conventional IVF. But either way, we're stimulating their ovaries with fertility drugs. So I'm going to do a kind of a chart review with you in just a moment geared towards that. Now, my other group of people are my recipient people. That would be people, surrogates. That would be people who are doing frozen embryo transfers. That would be people who are using egg donors. Those people are not stimulating. They're not taking fertility drugs. However, they are on a medication calendar. They're in a very important cycle, but it's just a little bit geared a little bit differently. So I'm going to have a separate video that's going to be geared towards the recipient individuals. So join me next at the next video and pick your group, and we'll talk next about how to prepare for your cycle. Welcome back. This is going to be the stimulation leg, if you will, of a chart review where we're going to talk about exactly how we prepare you for an IVF cycle. I hope to get lots of questions answered for you here. Remember, what I'm going to talk about here, I'm going to use, and you're probably looking at it right now, this is a sample stimulation calendar. This is what, in a general sense, almost all of the stimulation calendars will look like. Certainly, you're going to have different degrees and different strengths of fertility drugs that your doctor has prescribed for you for your protocol. Your protocol may be a little bit different than this. That's why you're going to have your own appointments with your coordinator in St. Louis to discuss the details of your calendar. But the calendar you're looking at now is going to be enough of a general sense for you and I to talk about how we plan this out, what can I expect kind of thing. But just keep in mind, this isn't necessarily reflect every calendar that's going to be out there for individuals. All right, now let's talk about planning this cycle. Now, one of the first things I like to talk about when I have my chart reviews with my patients is let's talk about dates. Let's get this cleared up right now because there's a lot of misconceptions. And again, I'm going to use, as my sample calendar will have on it, I'm going to use the April 29th cycle as our sample date to talk about. Now, again, I say this is April 29th. You may decide you're signed up down the road for a June 3rd cycle or a July 8th cycle or whatever the date might be. Again, your office there in St. Louis, they'll make sure and let you know what all the upcoming cycle dates are. Whatever those cycle dates are, it's the same thing as me talking about April 29th. So let's talk about what that date actually means. Now, April 29th, and you'll notice on the medication calendar that you've seen, and I've got right here in front of me, April 29th is literally the last day of this medication calendar. Well, it looks like it's the last day of this medication calendar, but it's really not. It's just the last day of this specific calendar. April 29th is your first appointment with the doctors to begin your follicle monitoring ultrasounds. This is going to be your first appointment in St. Louis to see the doctors. You will, now to put that date in perspective for a minute, you will have already began your injectable fertility drugs 6 or 7 days earlier. You're taking them, you're there at home doing them every night. We don't need to do any monitoring during that time. Your body is just busy, hopefully growing plenty of follicles, but come along on your cycle date, April 29th, for our example. That is when your first appointment is going to be in the office so the doctor can do their first ultrasound to check things out. Specifically, how many follicles do I have? How big are they? How am I doing? Okay. Based on what the doctor sees on that day, we're probably going to continue doing some monitoring. Now, of course, everybody is different. I'm going to kind of give you a law of averages here of what most people do. But of course, like a bell curve, I have some people that do things markedly earlier and I have some people that do things markedly later. On average, when you come in and see the doctor for the first time on April 29th, he or she is going to tell you how you're doing and probably going to tell you, all right, we're looking good. I want you to stay on the medications and maybe come back and see me tomorrow. Or maybe skip a day and come back and see me on Wednesday. But for 2, maybe 3, maybe 4 days, you're going to do these follicle monitoring ultrasounds. At the same time as the days that you do your ultrasounds, you're probably going and getting estradiol blood work done as well. That helps the doctor determine how far along the follicles are and when we're getting to that point of being ready. And while you're continuing on, all we're doing is extending this medication calendar. So that's why I say it looks like this calendar stops for you on April 29th, but it really doesn't. It's going to continue on depending on your body, depending on when you're going to be ready. And we're waiting for these lead follicles to get anywhere from that 18 to 22 millimeter range. Now you're going to have follicles scattered all over. Now, in my perfect world, they would all measure the same thing at the same time. And sometimes we get that, but what's normal is follicles will grow at whatever rate they're going to grow at. And what the doctor, and this is the art of IVF, that doctor has to make the decision of when you're ready. Again, waiting for those lead follicles to get big enough. Now, this calendar, as all of our calendars will say, will always have down here somewhere a probable HCG injection. Now, HCG is what we often call a trigger shot. Now, whenever the doctor says, okay, you are ready for your trigger shot. You have those lead follicles right in the range that I like. And I think, without sacrificing those lead follicles. I don't want them to get too big, but trying to wait for those smaller ones. I think this is the best time for you to do this trigger shot. Now, most people will be doing their trigger shots, like I say, maybe 2 or 3 days later. This HCG trigger shot, that's done at a very specific time. It's done at a very specific time. It could be anywhere 35, 36 hours ahead of the egg retrieval. This injection, what it's doing is it's kind of mimicking like an LH surge in your body. You know, you have that LH surge right before you ovulate, and that helps mature up eggs. It helps loosen up those eggs in the follicles. It gets you ready to either ovulate, or in our case, it gets you ready for your egg retrieval. And so we time that HCG trigger shot according to the exact time of your egg retrieval, roughly 2 days later. So again, when you're in the cycle, your coordinator will go over the details of exactly when you're going to do your HCG trigger shot and what time. Now, the beauty of this shot is it's going to give you and I 2 days notice of your egg retrieval. So again, right now we're just talking about dates. I need to know when I'm going to be busy there in St. Louis. Egg retrieval's a big day because generally that is a down day for you. That's a day off work. That's a day I need you pampered after the egg retrieval. And it's a day, technically it's the only day, I need your partner. Now, if you're using donor sperm or you're using a frozen backup, well, that makes things pretty easy. But if you are using your life partner, then this is it for him. This is his official appointment date. Now, like I said, I'll give both you and him the 2 days notice. So that way you know for work or arrangements or what have you, that your egg retrieval is going to occur 2 days later. Now, in general, egg retrievals usually occur around Friday, Saturday-ish. They could occur as early as Wednesday. They could occur as late as the following Monday, because remember, everybody's different. But certainly when I start monitoring and you get those ultrasound appointments beginning on Monday, we're going to have a good idea where you're going to lay. But probably somewhere around that weekend time period, we're going to be ready for that egg retrieval. Now, egg retrieval is going to happen right there in the clinic. We have a little operating room right there in the clinic, and the doctors use a nurse anesthetist, so you are going to be getting an IV anesthesia. You're not going to remember the egg retrieval. You're going to be perfectly comfortable. That is our job to make sure of, so I don't want any way for you to stress about the egg retrieval. Now, most of you know how egg retrievals are done, but just in case you don't, they are done vaginally with a needle, goes through the vaginal wall and goes up to each one of those follicles the doctors have been watching on these ultrasounds. And the doctors are going to empty every follicle you group, big and small, all the follicles emptied, and we're going to collect those eggs. Now, the egg retrieval might take 15, 20 minutes. It's not a very long procedure. You wake up rather quickly from the egg retrieval, and we kind of take care of you and rouse you up from your sleep, and you're probably hanging out in the clinic for a half hour, 45 minutes after the egg retrieval. During the egg retrieval, generally your partner is in his own room giving his sample for the cycle, or maybe perhaps he's opted to want to bring the sample in when he comes in, which is an option as well. Now, at the point of egg retrieval, like I said, the doctor's going to empty all those follicles. We're going to pass those over to the lab. The lab's going to take a look at them. What we're going to learn on the day of your egg retrieval is how many eggs did we get? Okay, now we're also probably going to learn how many of those eggs are mature. Because remember, when we were doing all those ultrasounds, we had some follicles bigger than others, and this is a matter of, a lot of times people ask me, how big were my eggs? It's not the size of your eggs you're looking for. Did I get mature eggs? And again, those bigger follicles, we hope give us those mature eggs, because it's only mature eggs that eventually will fertilize. So that's an answer that we're going to get on the day of our retrieval. How many eggs did I get, and how many were mature? Now, since we're talking about numbers now, there is a natural attrition rate that occurs in IVF, because I know a lot of you are out there and you're on the internet a lot, and you've got cycle buddies, and you're comparing notes, and you're looking to see what a lot of other individuals do. And I should go off on a tangent here for a minute and talk about the internet, and I will. But what's average? Well, what's average? That's tough. But I would say on average, I might see 10 to 15 follicles in an individual. And this is the attrition rate that I want to talk about, because again, just because you hear somewhere or you read somewhere, somebody got 20 eggs, or a lot of times people translate that to mean, oh, they ended up with 20 embryos or all of these big numbers. But what is real is the attrition rate that occurs. And what I mean is we're going to come down. We're going to go down. That's going to happen with everybody, whether you start with 3 or whether you start with 33. Now, the doctor may have been measuring, let's say in our example here, this gal was is measuring 12 follicles throughout. And we get over to egg retrieval, and she may end up getting, let's say we're lucky, we get all 12 follicles. We get all 12 eggs from all the follicles, but let's say we get 10 that are mature. Well, there's our first drop down. Again, very normal, because again, we're going to be losing a few along the way. Now, the older you get, the more of a challenge this is, obviously. My tangent about the internet is careful what you hear and careful what you read about and what you compare stories about, because you've got to keep in mind when you're out there on the internet, which is great support for you, and it's great support for you for people who know what you're going through, and that's what I want the internet to be for you. I don't always want the internet to be your resource for the information you need to have for your cycle. Okay, because the information that's put out there, well, for one, it's, I'm going to say sometimes it's slanted. For example, let's say everybody in a cycle, gets certain results, and 10 out of 20 gals decide they're going to go out there and start posting their results. Well, you may find that the 10 gals who did very well in the cycle are really out there boasting and throwing their numbers out. But the gals who didn't do that well or feel disappointed, well, they might not want to be out there posting all about it. So what does that mean to you as the reader of all this? Is if you're a gal who maybe did a little below average, you're going to think, oh my gosh, is it just me? I mean, look at how good everybody else did. I'm the loser in the group. And the reality is you're not. But again, this is the way sometimes how slanted information can be on the internet. Again, people tend to only report good stories sometimes, or maybe they're reporting in such a way that they're highly optimistic because it's what they want and need to believe. But again, a lot of you guys can take that to heart, and I don't want you to. So that's my tangent about the internet. So now we're talking about the numbers that we're getting, and we're at egg retrieval. And again, in our example, maybe we've got 12 eggs and 10 were mature. Now, you're recovering that day. You're taking it easy. In the lab, later that afternoon, they're going to do what is called ICSI. Now, ICSI is where embryology is going to pick one sperm at a time and inject it into each one of those mature eggs. Now, it's kind of like a horse to water thing. Embryologists can put a sperm in an egg, but that doesn't make an egg fertilized. As hard as it is to believe here, there's a lot of what we do here that is based on nature. As a matter of fact, probably the most important stuff that's going on here boils down to nature decides what to do. And fertilization is one of them. We leave these guys alone overnight, and we learn the next day how many of those 10 mature eggs fertilize normally. And maybe out of 10 mature eggs, we may have 9 that fertilize normally. Again, not all of the eggs are necessarily going to fertilize. And now we're moving forward. So now we're probably getting towards the second week of the cycle. Because in general, when you pick an IVF cycle, and when you're doing a conventional IVF cycle, and I'm going to talk about different kinds of stimulation cycles in a minute, but when you're doing just the old-fashioned conventional IVF, you're going to want to block about 10 to 12 days of your life being busy in this clinic. Now we're on to the second week of cycle. We're about getting into the Sunday, Monday time period, and you're waiting. You're on standby, and you're gathering a lot of information from us because we're basically waiting on these embryos. Now, we've learned about the fertilization the day after the egg retrieval. Call that day 1. Now, day 2 is a quiet day. Embryology leaves these embryos alone, so nothing to update on day 2. Now, day 3 is going to come along. Day 3 is going to come along, and embryology is going to assess these embryos. Now, usually what you like to see on day 3 is you like to see embryos in about the 6 to 8 cell range. This is their only job in life. They're dividing 2 cells, 4 cells, 6 cells, 8 cells, etc. In general, you don't necessarily want to see real slow-growing embryos. They don't tend to be too promising. Likewise, you don't want to see embryos that are growing at the speed of light. That's not very promising either. Not to say that both of those scenarios can't make normal babies, because they can, but just statistically, it's certainly not as successful as those embryos that are in that nice, juicy 6 to 8 cell range. Now, we'll update you on day 3. We're going to let you know how do things look. Not that this is the end of the story, but at least I've got to give you an update on how things are progressing. How do they look? Now, sometimes I call day 3 halfway through the marathon, meaning it's not that hard to make it to day 3. And we want to be optimistic, and when you're doing well, and maybe out of those, my example, out of those 9 fertilized eggs, I have 7 of them that are growing well. They got a couple of slow ones. Everybody's got those, but I've got 7 of them that are in that nice meaty 6 to 8 cell range. And they got a hard job ahead of them now. We're going to keep culturing these embryos, and we're going to culture them out till we get to that blastocyst stage. Now, that's a developmental stage where they're up over 150 cells, no more counting cells after day 3. We just talk more about the developmental stage they're at. Now, day 4 is in the middle there. And again, we don't tend to really update you about day 4 because we're not getting to that developmental stage we need to, which is the blastocyst stage. Now, by and large, we do day 5 or 6, or I should say we do blastocyst transfers. Some of you might ask about, well, sometimes I don't make blastocysts, and what do you guys think about doing a day 3 transfer? Now, one thing that's good for me to say right here is if you've got an embryo, and that embryo is a nice, healthy, normal, competent embryo, it's going to make a baby in you no matter what day I put it back. If everything is good with you in that uterus and that soil environment, and this embryo is normal, whether I transfer it on day 2, 3, 4, or 5, it's going to make an embryo, a baby for you. So the day of transfer has a lot more to do with selecting the right embryo and having confidence in the embryo quality when we go to do the transfer for you. Now, oftentimes, like I said, you've got too many embryos on day 3. I don't know what embryos I'm going to be put back. A hatful of them look good, and it wasn't hard to look good. Mother Nature really hasn't done her job yet to cull out those abnormal ones, and that's what Mother Nature's going to do between day 3 and day 5, is she's going to cull them out because depending on your age, this of course varies a lot, but you might find that 30 to 50% of good day 3 embryos are going to make it to that blastocyst stage. Again, that's very dependent upon age and this kind of thing. But eventually we're going to get out to day 5, and embryology is going to let us know how many of those, let's say 7 embryos, made it to that expanded blastocyst stage. And I may end up anywhere from 2 to 4 embryos making it to that expanded blastocyst stage. Now, if they didn't make it to that stage, which is the end of the marathon, remember, a lot of us can look good halfway through. The question is, and that's day 3, the question is, how do I look at the end? How do I look on day 5? And that's where we're going to get our answers. So the embryos that don't make it to that expanded blastocyst stage, well, Mother Nature just told you those weren't going to make babies. So now, and of course now we've culled down, whereas I had 7 good looking embryos on day 3, maybe I'm down now, like I said, to 2 to 4 blastocysts. And of course you'll speak with your doctor about how many embryos should I transfer. If you've got immune issues, that might impact whether we transfer 1 or 2. Most often we're transferring 2 embryos. Nobody wants triplets, so 3 embryos is a rarity that we transfer. But in general, as long as you're okay with twins, 2 embryos is probably the most popular. And of course, whatever in the expanded blastocyst, whatever we don't transfer is going to get frozen or vitrified. That's that flash freezing. Now, the transfer and the freezing I mentioned could happen anywhere from day 5 to day 6. So if our egg retrieval, for example, were on Friday, then 1, 2, 3, 4, our embryo transfer might fall the following week on Wednesday or Thursday. Now, what to expect with embryo transfer? Well, this is literally going to be the day you're going to find out what's the deal. Well, how do the embryos look? And you're going to get a report telling you exactly what we've got, exactly what we want to transfer. You're part of that decision, by the way. That's very important. We're not dictating to you what you're doing in your cycle. Our job is to inform you, is to teach you about what's going on, and then with you, we're going to decide what's best to put back for embryo transfer. And we want you to speak up with your doctor. Maybe your first instinct is, I don't know if I agree with your recommendation. I understand it, but I don't know if I agree with it. Or maybe I need a little bit more explanation about that. I want to make sure that you speak up and you talk with your doctor about that, because again, this is your cycle. This is your outcome. And we want to make sure that as long as you're informed about anything, we're willing to do something that may even go against our recommendation. Because again, ultimately, this is your cycle. It's only our responsibility to teach you and make sure that you're making an informed decision about things. And we respect that that's your decision. So we'll have this conversation where we'll talk about the embryos. Now, for the embryo transfer, generally it's not anything that's uncomfortable to have done. I mean, I say that, and I'm a gal who's had a speculum before. That's not pleasant, but it's not anything that's horribly uncomfortable. Now, we give you a little Valium ahead of time because we like you to be plenty relaxed for the transfer. the transfer, probably the rate limiting factor here on making or breaking a cycle, because you could have a gorgeous uterus, you could have beautiful competent embryos, but if you're not having the embryos transferred in the appropriate manner, meaning I want it under ultrasound guidance, I want to be able to see where that catheter is going in the uterus, I want to see those embryos, I want to see them inserted into the uterine cavity. All of these things are critically important to your doctor. Now, getting ready for the embryo transfer, one of the things you're going to be told, and probably you've heard about, and it's freaking you out, it would me too, and that is this full bladder type of thing. Now, we need a full-ish bladder for transfer. I don't need it overfilled. If you're in pain, you're usually too full for me. Now, there's a strategy to getting that just right, but ultimately, don't stress about it. The doctor can always use a little fine catheter, let a little water out, put a little water in so we can make that bladder just right. Now, that bladder is really important. I wouldn't just do this to torture you. It's really important for a couple of reasons. One, I need that bladder to help position that uterus flat for me. So that way we've got that straight line coming in to do that embryo transfer. Now, too full of a bladder and I've smushed that uterus. I don't want that either. So that's why I say that doc will fine tune that for you and get that just right. But even more important is the full bladder turns on a part, I'm going to take you back to old biology and anatomy class, turns on a part of your autonomic nervous system that helps prevent cramping in the uterus. Now, the embryo transfer itself and your partner is certainly welcome to be in there with you. It's a very special time. It's my most favorite time of this. As a matter of fact, I'm usually the one doing the ultrasound on your tummy, not always your most favorite person at that moment, but so that way the doctor can see what they're doing for transfer. But the transfer takes, it's a 15-minute procedure, and whatever it is, 1 or 2 embryos, whatever we're transferring, are loaded up in the catheter together. And then, like I said, with just a little fine catheter, the doc can see where he's going, and it'll go right into that uterine cavity, and he'll inject both of those embryos, and that embryologist will take that catheter back to the lab, make sure those embryos are out of there. We'll actually be able to see them on the ultrasound. Well, we can actually see the drop of fluid both embryos are in, and that way we know the placement is very good. Now, you're going to kind of just chill out here in the office for about an hour, and you're going to go home and just be a couch potato overnight after the embryo transfer. And I know, again, you're out on that internet, you're reading, I need 3 days bed rest, I need all these kind of things. Well, the answer to the question of what do I really need to do after an embryo transfer? What do I really need to do to try to help make sure these embryos implant? And the answer to that question is, what does nature do? What do they do? What did your mom do? That's right, nothing. So the reality is as much as I throw you a couple of conservative restrictions and these kind of things, we put those embryos back. They're not falling out of you. You're not going to stand up and have them fall out. They're either going to implant where they are, they're going to do, this is that part where I told you we're back to nature again. Totally out of your hands, completely. You couldn't do anything to make this happen, and you cannot do anything to make this not happen. All right. Like I always tell my patients, think of yourself as that teenage girl who didn't want to be pregnant. What could she do to undo it? And we all know there's nothing you can do to undo it. So likewise for you, there isn't. Though, like I said, we throw a couple of restrictions out there for you because why not? Why not pamper you a little bit and just be on the safe side? But the reality is you couldn't do anything to make it not happen. So it's out of your hands. And what I want you to get from that is stress levels down. Okay, I don't want you. I'm probably more worried about stress levels and you being crazy about things. Should I be walking? Should I be taking the stairs when I get home? What side should I lay on? Should I be flat on my back? These embryos are going to implant, or they're not going to implant. And there is very little that you're going to be able to do about that. Now, that takes us, like I said, to the end of the cycle. There's about the end of that. What I said is about a 10 to 12 day commitment in the clinic. Now, that's what that cycle date, we started this all out talking about what does that cycle date mean I pick? Well, that's day 1 of this 10 to 12 day fun that you're having here in the clinic. But a lot of things, and you can see on this little pretty color calendar, and you'll receive one like this as well, there's a lot of things that are going on before April 29th. Okay, now medication-wise, you're beginning medications about 2.5 weeks in advance. Now, of course, we knew we started first that birth control pill a month in advance, but eventually you are going to be on injectable medications, like I say, about 2.5 weeks before you even begin the cycle monitoring. Now, like I mentioned earlier, there's a specific injection instruction videos that go through the details of your medications. I'm going to be just general in a sense here, just talking about what IVF medication calendars look like and what you're on and why you're on it. Now, basically, there are really just a couple of things we're doing in this pretty colorful calendar here. One is the obvious. That is the fertility drugs. Follistim, Gonal-F, Menopur, these kind of things. You're taking those drugs because, of course, we're stimulating the ovaries, and your doctor has determined your protocol based on either previous stimulation or maybe your cycle day 3 labs or your AMH level, these kind of things. So certainly medications are geared towards stimulating those ovaries. But what we've got to start earlier on, and you're going to see that starting earlier and higher up on your calendar, is you're going to be on medications that are going to down-regulate your pituitary. Now, these are medications like Lupron. These are medications like ganirelix or Cetrotide. Now, sometimes you're on a calendar where you're only on Lupron. Sometimes you're on calendars where you're doing Lupron and segueing over to a ganirelix or a Cetrotide. Either way, these drugs, Lupron, ganirelix, Cetrotide, they're all geared towards keeping your hormones quiet at the pituitary level. I don't want you helping. I don't want you giving me any of your own FSH or LH. I don't want you certainly ovulating later on. So in order for us to have control over these important hormones, which, by the way, your fertility drugs are the same FSH and LH I'm talking about, we're going to give you those in very controlled amounts. I just don't want you participating. And that's what the Lupron and the ganirelix and Cetrotide are about. They affect your pituitary, okay, so you don't release those hormones. Now, a lot of times people think, oh, I can't be on Lupron. My ovaries get oversuppressed on the Lupron and these type of things. But again, Lupron isn't affecting your ovaries. Lupron is only keeping your hormones quiet so you're not participating. We're going to give you back everything that you're going to need. Now, in the beginning of your medication calendar, you're going to see, and this is what I mentioned earlier, this birth control pill is all about timing. The birth control pill is overlapped with the Lupron for a little bit, and I'm going to stop that birth control pill at a very specific time because that's going to give me a period. Now, it's a fake period, but it's giving me a period because this is how I begin the timing of this cycle. Now, during this period, you'll see on your calendar, your coordinator's got you scheduled to have a baseline ultrasound and an estradiol blood test. Those are just to make sure everything is quiet on those ovaries before I start up with those stimulation hormones. Don't want any large cysts. I don't want to find anything unusual. We want to check that out and make sure everything's okay. I want that ultrasound to be quiet, and I want that estradiol level to be nice and quiet as well. Should be. We haven't been doing anything yet. Then eventually, like I said, you're going to start up with your fertility drugs, whether it be Follistim or Gonal-F. And again, your calendar will be geared towards your exact dose. Now, our calendars tend to start out a couple of days, the first few days on that stimulation drug being a little bit higher than the rest of the days. This is because we're giving those ovaries a little bit of a bigger push in the beginning to recruit those follicles, etc. And then we're going to kind of have a cruising dose of our fertility drugs moving along. Now, if you don't already know it, the Follistim or Gonal-F you're on, that is your pure FSH, follicle stimulating hormone. That is what is growing these follicles for us. That's what's recruiting these follicles. Now, you're going to find on your medication calendar, you're on some form of Menopur as well. A half a vial every day, 1 vial every other day, same thing. And the Menopur is allowing us to give you a little bit of LH or luteinizing hormone. You got to have a little, not too much, but you've got to have a little bit. Now, I know some of you will say to me, oh, no, I know my doctor talked to me about LH is bad, and I don't know if my usually your doctor has specifically talked to you about maybe previous protocols you've been on, or you've been on very heavy amounts of Menopur, or maybe even equal amounts of LH-containing drugs like Menopur, Brevell, along with your FSH drugs. That's not what's natural. That's not what your body does. Your body has a little bit of LH around normally, and we're trying to replicate that thing. So that's why you're going to, in one form or another, you're going to have a little bit of Menopur around. Again, I'm not going to go through the details of exactly how you do all these medications because you'll find that elsewhere on our website with injection instructions. Generally, what else would I find on this medication calendar? Usually you'll find some form of a steroid. Now again, could be dexamethasone, could be prednisone. It all depends on what your doctor's prescribed. Do you have other immune issues going on? But regardless, you're on some form of a low-dose steroid, mostly for its anti-inflammatory benefits. We don't want any kind of inflammation reactions, preventing these embryos from implanting. So we start that steroid early on because it takes a bit to have its effect in your body. Now, what else could be going on in this medication calendar of interest? Now, well, you could be getting other immune treatment. You could be getting, for example, on this calendar, I've got Intra Lipids. Intra Lipids is an IV infusion. Now, not all of our patients are going to need that. A lot of our patients do. You've got natural killer cells. You've got this matching DQ alpha thing. For whatever the reason is, you've got immune issues that the doctors have prescribed Intra Lipids. Now, Intra Lipids is as simple. It's about a 3-hour IV infusion, and as long as you're not allergic to soy or eggs, it's kind of like a super nutritional supplement just done through an IV. Pretty boring otherwise, and luckily not something that's expensive. But it is something that's given to you to help prevent your body from rejecting these embryos. Again, maybe you've been told you've got elevated natural killer cells. All right, elevated natural killer cells. This is what I call, and I'm going to use I use a lot of dog analogies. This is my Rottweiler immune system. We all have natural killer cells. That's a good thing. Maybe you have this elevated level. They're activated, what have you, for a reason that usually your doctor will try to find out that reason. But it's probably an immune system that's keeping you probably pretty healthy, but because it's what I call the Rottweiler immune system, sometimes it starts attacking things that are foreign to you that it shouldn't be, like embryos, because of course embryos are half your partner. So we don't want that to happen. I need to counteract that super duper immune system. And Intra Lipids is what is given to help protect those embryos against that kind of a natural killer cell effect. DQ alpha issues, and I kind of go off on a little bit of a tangent here, because this is what I do in my chart reviews. We go off on tangents, is DQ alpha. This is when you've probably been told you and your partner might have this matching immune gene. Little bit more of a challenge to overcome, still intralipid treatment, but it basically just tells us that you and your partner have similar immune systems, not something necessarily nature is happy about. Nature would rather two people with very different immune systems get together to have a baby, to have a very diversified immune system. So if you have that similarity, it's usually just a partial type of match, and it doesn't mean it isn't something that can't ever be overcome. It can, but it might present a little bit more of a challenge. And so that's why your doctor will talk to you a little bit more about what those challenges might be. Intra Lipids is generally infused at freestanding infusion centers or hospitals or what have you. And again, your coordinator will work with getting that arranged for you. Now you've kind of learned about timing, date-wise. All right, dates. I know when I'm going to be busy in the clinic. I understand now, calendar-wise, when I'm going to be on medications. Maybe I'm going to be traveling while I'm on these medications. Not a problem. Take them with you. We give you a travel letter. Just want to make sure you're around for your baseline appointment, or at least you can get your baseline done wherever you are. We know we've got to start that birth control pill at least a month in advance. Now, prior to getting to this point of all these medications, your coordinator has probably gone through with you, what kind of testing do I need to do to get ready for this cycle? Now, if you have cycled elsewhere, we will happily use any results we receive from previous clinics or outside laboratories, as long as it's within 18 months. So always make sure you get us your records. That helps you, that helps me, it helps the doctor. So if you've got outside records, make sure you get those to us. Otherwise, there is a standard list of infectious disease testing for both the male and the female. A couple of hormones on the women. Couple of other, maybe a CBC, a blood type, rubella, this kind of thing. The husbands get his infectious disease testing and his semen analysis, and of course he's done. One of the most important things you've got to get done when you're doing a conventional IVF cycle like this with a transfer is you've got to have your uterine assessment done. Generally, it's what's called a sonohystogram or a fluid ultrasound or a saline ultrasound, where you're having saline injected into the uterine cavity, inflate it like a little water balloon, so that we can make sure there's no polyps or scar tissue or fibroids or anything in that cavity that would prevent embryos from implanting. Again, this is the kind of testing you're usually doing in that month prior to your cycle. Your coordinator will go through all of that with you, but that uterine assessment could be in the form of a hysteroscopy as well. It is generally not in the form of a hysterosalpingogram. That's that dye test. That injects the dye and it looks at the tubes to see if the tubes are open, but it doesn't actually take care of inflating that uterine cavity enough and exposing that uterine cavity enough for us to make sure there aren't anything, polyps or what have you, that would prevent an embryo from implanting. And if something were like polyps were found, well, we'll just get you scheduled for a hysteroscopy to get those snipped out. We don't even have to miss a beat. But that's a very important test your coordinator is going to go over with you to get done ahead of time. Now, where do we get all these medications at? I don't know where to get these medications at. Well, your coordinator will take care of that for you too. Generally, we're using a mail order fertility pharmacies. They tend to be the least expensive. You don't want to go down the street to Walgreens or Rite Aid. It's going to be too expensive. So we'll usually send off a full medication order to the mail order pharmacies, and they will take care of sending the medications to you, or if you want them sent to the clinic to pick up, you certainly can. If you're lucky, maybe you have insurance coverage for some of your medications, and of course your coordinator will work on getting prior authorizations done for you, whatever's going to be helpful to get those medications covered for you. Unfortunately, they're not covered all that often. So that's about, in general, the preparatory work that has to go into getting ready for a cycle. Like I said, things I've told you here are good general follow-throughs on what we got to get done for a cycle. Your coordinator will be more specific if there's something different for you, or if you hear about something that's different for you and you want more information. Please, my patients know this with me. You always contact your clinical coordinator. You are not bothering her. This is what her job is to do, is to answer your questions and make sure you're informed about everything. And I gave you my email address, lindavie@sherinstitute.com. You're always welcome to contact me for anything, any questions that come up. Now, I'm going to make a little separate video here about an important topic. I don't want you to think I've left it out here. And that is when you're doing an IVF cycle like this, PGD, CGH, genetic testing, that's becoming very popular. Now, since I'm talking about a stimulation calendar, and again, I'm going to have a separate video just because it doesn't necessarily apply to everybody, but it's a lot of information about the different types of genetic testing you can get done. Some of you may be doing a stimulation calendar in a format that we might call a staggered IVF, where you're not, well, it's staggered. You're going to do the stimulation part of an IVF. You're going to create the embryos, but you're not going to transfer them yet. We're going to freeze the embryos, generally because we're awaiting some kind of genetic testing results. And then you're going to come back staggered for that second cycle, that frozen embryo transfer, where we'll plan a frozen embryo transfer cycle. Those who are doing a staggered IVF or a freeze-all or what have you are still on this kind of, and as I described the embryos and what's going on with all of them, that's all still occurring for you as well. It's just that technically in a staggered IVF, you're finished after the egg retrieval. So your stay in St. Louis might only be a week, might be 5 days, just long enough for you to get the egg retrieval, and then you're done. Of course, we're still busy in that second week of cycle because we're working on those embryos. We're taking them out to that blastocyst for freezing. Now, if you're doing one of those stagger type of cycles, you're not on some of these medications. You're not on the medications geared towards transfer. You're not on a steroid. You're not doing Intra Lipids, this kind of thing. That's all going to come later in your frozen calendar. So I'll talk a little bit more about CGH in a little separate video. I just didn't want you to think I was ignoring that here. All right, I think that's it for this.